I wanted to thank you for giving me the opportunity to talk to you about one of my passions in life, which is prostate cancer. I started studying prostate cancer as a medical student, and I did a lot of research when I was in the MD PhD program at the University of Colorado. After I had invested quite a few years on it, I thought, well, I might as well go into urology, otherwise I've done all this studying for nothing. So let me talk to you a little bit about what's new, both in the diagnostics and in the treatment of prostate cancer, some of the newer concepts. So there's definitely some really exciting stuff coming down the pipe that I would like to share with you. The most important thing that I'm going to do is review a little bit the anatomy of the prostate and the urinary system. It's not the kind of system that we see that often, so I thought it would be a good idea to kind of discuss some of the aspects of this anatomy that can affect not only prostate cancer, but also patients in general. So in this first picture, what I want you to notice is, well, the bladder is pretty obvious. This is the area of the trigone. These are the urethral orifices as they come into the bladder. And the reason why I was showing you the trigone area is because when you have patients that have metastatic prostate cancer, sometimes they have so much local invasion into the bladder neck and the trigone area that they can end up with hydronephrosis and complete ureteral obstruction going into renal failure. So, and now you can see why. You see there's really not that much of a distance between. Also, if you look at the prostate itself, I always tell people the prostate is like an orange. You have the meat of the orange, and then you have the capsule. And believe it or not, the capsule is a little bit of an extension of the pelvic floor, which is also the external urinary sphincter, okay, which is under voluntary control. And this is the internal sphincter, which we call the bladder neck, which is, of course, not under control by us. So what you see here is you see the two ejaculatory ducts and you see the utricle. The utricle is actually the uterus, the remnant of the uterus that has become atrophied because they were not the right hormones. Unfortunately, it's an open blinded, it's kind of like a bag, and sometimes it's like an appendix in a way, and they can become infected. Some of the people that complain a lot about that chronic prostatitis can actually be due to an infected utricle. Now, the one thing I want you to notice here is you see how many little openings there are? All of those, every gland of the prostate opens into the urethra. And the reason why that is significant is because even if you have a prostate that is not infected, if you have a situation where there is a blockage, or you have a very tight pelvic floor, or you have a urethral stricture, you can then push some of the urine coming out into the actual prostate gland. And you know that most of people's urines in the United States is a pH of 5. So even if you don't have an infection, having a pH of 5 fluid going into these glands can cause a lot of the inflammation. As a matter of fact, only 10% of people that show symptoms of prostatitis is due to infection. The other 90% is more musculoskeletal or inflammation. Now, why am I telling you all this nonsense about prostatitis? You go, am I in the wrong place, or is she delirious? The truth is, we know that people that have chronic inflammation, chronic infection of the prostate, enlarged prostate, that can be one of the precursors to prostate cancer. So I just wanted to make you aware. Another misnomer, because I see a lot of practitioners here, many people say, my physician or my nurse practitioner or my practitioner went ahead and did a rectal exam, and they say my prostate is not that large, so why am I having trouble urinating? The reason being is the prostate can do one of two things. It can be really tight because the capsule of the prostate is tight and kind of block, kind of squeeze the urethra, and they cannot urinate. And they may have a 20-gram prostate, and you go, wow, that poor person can't urinate. What's up with that? That's because they have a very tight urethra. And then you have other people that can have, prostate growing outward and have no obstruction symptoms whatsoever. And the biggest prostate I ever saw, of course, was in Texas. And it's no joke. It definitely is no joke. That's where I trained, okay? That thing was like 200 grams. I mean, this was bigger than a grapefruit. And the guy had no urinary symptoms. So just so you know that. Okay. The other thing that I was going to show you is this is the rectum here, and this is our prostate, okay? And it's fortuitous that 95% of the prostate cancers are going to be found in an area of the prostate we call the peripheral zone, which is right here. And so one of my, I think you guys all know, what is the only excuse not to do a rectal exam? Is when somebody does not have a rectum, okay? And I mean that, and I will prove to you why that's important as we go, I promise you. All right. You may say, well, that's kind of weird. Why would this area of the prostate have 95% of the cancers and only 5% of the cancers in this other area, which we call the transition zone and central zone? The truth is, embryologically, they come from two different places. One comes from mesoderm and the other one from ectoderm. And who cares about that? Those are fancy words. But what's important is that at the research level at Baylor, we were trying to figure out, well, that's kind of cool. If one area never gets cancer and the other one always does, is there something that we can compare? Is there something that protects one and not the other? So a lot of our research with tumor suppressor genes and proto-oncogenes and things like that was directed towards trying to find a difference. Anyway, the reason why I'm showing you this picture is because sometimes prostate cancer is very likely to invade the seminal vesicle, okay? And we call that metastatic disease. Mostly local, of course, but that's still very curable, okay? And the reason why that's important, and I will teach you more about that as we go, is because some of the modalities that we use for treatments of prostate cancer, primarily radiation and different types of radiation, have something that surgery doesn't have, which is called the cloud effect. Okay, so if you look at the rectum here and you see the prostate, when we're doing a radical prostatectomy, truly you have to peel one from the other. That's how little space there is in between them. So we have to be very careful. So if somebody has already a little bit of cancer outside the prostate, okay, and we're trying to peel that away, we're going to leave cancer behind, and that's not a good idea because then you haven't cured the patient. We know that the rectum can take certain amount of radiation and be safe, and you can place the treatment in a way where you could try to cure this area. We can also implant seeds inside the seminal vesicles, okay, and get a cure out of that patient. All right, and the only other area I wanted to show you here, these are not eyes, there's actually ejaculatory ducts. This is the urethra. Look at how every prostatic gland goes into the urethra, but it's a double-edged sword. Urine will come in as well and really cause that chronic inflammation, which sometimes you'll see stones when you do x-rays, and that heaviness and painfulness that people have in the prostate itself.